All right, it is 12 o'clock, so we'll go ahead and get started. Good afternoon, everyone. Welcome to the Department of Medicine Grand Rounds this week. I see people trickling in. I'll start with some opening comments. So first, we have spent a lot of time this year really thinking about our schedule for Grand Rounds, and I'm really delighted with the lineup of speakers we have coming to Colorado. Next week, we have Dr. Christine Castle, who will be here. She will be delivering the 2025 Meiklejohn Lecture. The title of her lecture is Academic Freedom, Constructive Dialogue, and Flourishing in Medicine, We Need to Talk. And so I can only imagine how important and powerful that speech will be. For those of you who don't know, Dr. Castle is with the AMA. She used to be the CEO and president of the ABIM Foundation as well. So she really is an authority in this space. The following week, we'll welcome a dear friend of mine, Dr. Akbar Walji from the University of Michigan. Dr. Walji is a native of Kenya and has spent a lot of his time thinking about how to scale large-scale technologies in low-middle income countries. He's also an AI guru, much before we even talked about AI. And so his talk is about learning health systems in AI for low resource settings. And he will share with you how they've harnessed things like text messaging, geopositional location, and various aspects for preventing diseases like malaria, TB, and dengue in Africa. Truly a remarkable story, and I think an incredible talk that you will also receive from him. So in that spirit, today it is my honor to also welcome another distinguished speaker, Dr. Shalendar Bhasin. I'll tell you a little bit about Dr. Bhasin. He's a board-certified endocrinologist. He's also a professor of medicine at Harvard Medical School. He serves as a director of the research program in men's health, where he actually sees aging and metabolism at the Brigham and Women's Hospital. He also there leads the Claude D. Pepper Older American Independence Center and the Brigham Research Assay Core Laboratory. Dr. Bhasin earned his medical degree from the All India Institute of Medical Sciences in New Delhi in India. He completed his residency in internal medicine at Northwestern University and in fellowship training in endocrinology and metabolism at Harbor UCLA Medical Center. I could tell you a lot about Dr. Bhasin, but I'll just summarize to say over the past 4 decades, he has become a global leader in the biology of androgens, sarcopenia, and aging-related functional decline. His research has shaped clinical guidelines. It's informed public health policy, particularly around testosterone therapy, anabolic interventions, and then the development of function-promoting therapies. He has authored more than 300 peer-reviewed publications in journals such as the New England Journal of Medicine, in JAMA, and leading endocrine journals. He's been continuously funded by the NIH, and he currently leads multiple large-scale clinical trials, including the STRIDE study and the TRAVERSE trial, which I anticipate you'll hear about today. He's won numerous awards and accolades, including the 2025 International Medalist Award from the British Society of Endocrinology, and also the Lifetime Achievement Award from the Androgen Society. We are truly in for a treat today. Please join me in welcoming Dr. Shalendar Bhasin to the stage for Grand Rounds, where he'll talk about optimizing the diagnosis and treatment of hypogonadism. Dr. Bhasin, welcome.
Thank you, Dr. Chopra, for the generous introduction. Good afternoon. Can you hear me now? So I'm delighted to be here at University of Colorado. And I want to thank Dr. Chopra for the kind invitation, and to Maggie Weirman and Whitney Godler for their generous hospitality over the past day or so. So I'm happy to talk about a topic that I've thought about for most of my grown-up years, which is optimizing the diagnosis and treatment of hypogonadism. Here are my conflicts. In particular, I'm not speaking to represent the American Board of Internal Medicine or the Endocrine Society. Men's sexual health and aging have evolved in 3 epochs over the past century. The chemical synthesis of testosterone in the 1930s made testosterone available as a therapeutic for the treatment of hypogonadism. So testosterone was one of the first chemically synthesized drugs to be made available commercially for clinical use. Prior to the advent of radioimmunoassays, most men with hypogonadism had severe hypogonadism. And the clinical manifestation of severe hypogonadism were readily clinically apparent in the form of delayed or absent pubertal development, marked sexual dysfunction, infertility, breast enlargement, and small testes. The treatment of these men with severe hypogonadism with testosterone replacement therapy also produced clinically apparent benefits in terms of development of secondary sex characteristics, pubertal induction of puberty, marked improvement in sexual function and changes in body habitus that were also readily apparent. So the benefits and risks of testosterone were very favorable. And there was little controversy about testosterone replacement therapy for treatment of men with severe hypogonadism. In the late 1990s, with the approval of Viagra for erectile dysfunction, and with the availability of Androgel as an easy-to-use transdermal formulation, the word ED and low T came into the lexicon of dinnertime conversation, and it empowered middle-aged and older men with sexual symptoms and their partners to talk to their doctors about their genitourinary problems. Testosterone sales surged from around $18 million in the early 1990s to about $100 million in the year 2000 to over $3.5 billion by the year 2017. And since then, testosterone sales have continued. Thank you, Olivia. They have continued to grow, but at a more steady pace. Today, vast majority of men who are receiving testosterone treatment are middle-aged men, 40 to 65 years of age, who have mild hypogonadism and have multiple comorbid conditions such as obesity, diabetes, and heart disease. It is in this population that neither the benefits nor the risks of testosterone are clear-cut, leading to controversy. And this evolution of the epidemiology and the emerging heterogeneity of hypogonadal syndromes in men is reflected in these case histories. This 19-year-old man presents with failure of pubertal development, small testes, small penis, and anosmia. His physical exam shows loss of absence of secondary sex characteristics, female pattern escutcheon, and small testes. He has very low testosterone levels and also very low LH and FSH concentrations. His MRI shows hypoplastic olfactory bulbs, and further investigation reveals a microdeletion in the XP21 region, which houses the anosmin gene. The second patient, a 35-year-old man treated for acute myeloid leukemia with multiple bouts of cancer chemotherapeutic agents and bone marrow transplantation, which included whole body radiation, reports fatigue, loss of sex drive, and ED. He has a mildly reduced testicular volume, low testosterone levels, and mildly elevated LH and FSH. So in these first two patients, the symptoms, as well as the laboratory data and the self-evident etiology, leave no doubt about their diagnosis. And the treatment decision to initiate testosterone replacement therapy does not require a genius. The third patient, a 65-year-old man with hypertension, type 2 diabetes, complains of low sex drive, erectile dysfunction, low mood, and fatigue. His BMI is 35 kilogram per meter square. He is mildly hypertensive, has normal testicular volume, and his testosterone levels are just below the cut point. LH and FSH are in the normal range, and he's got multiple metabolic dysfunction in his laboratory values. So it's in this patient where you need additional data and evaluation to confirm whether he has hypogonadism, and the risk of misclassification is particularly high in this type of patient. The last patient is a 50-year-old man, and such patients we are seeing with increasing frequency in our endocrine clinics, who underwent radical prostatectomy for a low-grade Gleason 6 organ-confined adenocarcinoma 2 years ago, and his PSA 2 years after radical prostatectomy is undetectable, and he complains of sexual symptoms, which he finds very bothersome, and his total testosterone level, as well as free testosterone levels, are low, and FSH is mildly elevated. So he's got mild hypogonadism and very bothersome sexual symptoms, and the question is it safe to treat him? So these are the types of heterogeneous presentations of hypogonadism that we are seeing today, which I will talk about in my talk today. So I'll speak about the complexities in the diagnosis and strategies for reducing the diagnostic imprecision, the benefits and risks of testosterone treatment, and deriving inferences from recently completed TRAVERSE trial and the T trials. I'll also talk about how to optimize the monitoring to manage erythrocytosis and PSA elevations during testosterone replacement therapy, and then offer some concluding thoughts. So what is hypogonadism? Hypogonadism is not a discrete disorder, it's a syndrome that has two components. Testosterone deficiency due to inability of the testes to make normal amounts of testosterone, and subfertility or infertility because of inability to produce sufficient amount of sperm. So the diagnosis also, it follows, is based upon ascertainment of signs and symptoms and consistently low testosterone levels. Conceptually, the diagnostic evaluation of testosterone deficiency is very straightforward and very inexpensive. Step one is to ascertain signs and symptoms and to exclude systemic causes such as drugs. Opioids today and anabolic steroid withdrawal hypogonadism have emerged as the commonest identifiable causes of treatable severe hypogonadism in men. The second step is to confirm that the person has testosterone deficiency by measuring fasting, early morning total testosterone, and if indicated, free testosterone concentration. And then if the testosterone levels are low, then to confirm low testosterone by repeating the diagnostic evaluation and also measuring the free testosterone concentration. The third step, when you've confirmed that the person has testosterone deficiency, is to ascertain the cause, and it's done best by initially measuring LH and FSH to see if the person's defect resides at the testicular level as indicated by elevated LH and FSH, or at the central level as indicated by low or inappropriately normal LH and FSH concentrations. If the LH and FSH are elevated, then a karyotype should be obtained to confirm that the person has Klinefelter syndrome, a common genetic cause of primary testicular insufficiency. If the person has central hypogonadism, then you should go again into ruling out systemic causes, drugs such as opioids or glucocorticoids, measuring prolactin, ferritin, other pituitary hormones, and in many individuals, doing an MRI scan. And then you'll be left by process of exclusion with the diagnosis of idiopathic hypogonadotropic hypogonadism, which is also a heterogeneous group of disorders in which at least 75 mutations have been described, and every day the list grows longer. And by pattern recognition of dysmorphic features, you can identify discrete syndromes such as Kallman syndrome. In practice, particularly in individuals with mild to moderate degree of hypogonadism, the risk of misclassification is high. The sources of diagnostic imprecision and inaccuracy include the non-specificity of signs and symptoms, which in middle-aged and older men can overlap with those associated with aging. Sexual symptoms have the strongest association with testosterone deficiency, particularly low libido. Small testes, loss of body hair, tender gynecomastia are other more reliable signs. Testosterone levels vary substantially in men on different days and on different times of the year. Some of this variation is due to biologic factors, genetic polymorphisms, binding protein concentration variability amongst men, and secretory rhythms of testosterone. Testosterone levels are higher in the morning than in the evening. They are higher towards the end of winter than towards the end of summer, and testosterone is released in pulses every 90 to 120 minutes. Methodologic factors such as assay imprecision and inaccuracy and differences in assay calibrator contribute to inter-laboratory differences, which are very substantial. The reference ranges for testosterone vary across laboratories. This variation has decreased since the publication of the harmonized reference range that we've published, and I'll come back to that a little bit. But many laboratories still continue to report widely variable reference ranges, contributing to confusion. Fortunately, several recent developments over the past decade have greatly reduced the diagnostic imprecision. Testosterone level should be measured using an accurate assay such as liquid chromatography, tandem mass spectrometry-based assays that have become widely available from just about all the commercial laboratories. Immunoassay quality also has improved. Several CDC-certified immunoassays provide equal amount of accuracy and precision, but you need to specify the laboratory and the method. And you should specify a laboratory that is certified by the CDC's hormone standardization program. Also consider the effect of time, food, and illness. Testosterone levels should be measured in the morning to minimize confounding due to the diurnal variation. Testosterone levels should be measured in the fasting state to avoid the effect of food and avoid evaluating for hypogonadism during an acute illness. Reference range pertains to the distribution of an analyte in the general population. It defines low, normal, or high concentrations of the analyte and are the fundamental basis on which we make the diagnosis. And yet, very little attention has been paid to generation of harmonized reference ranges that can be applied like hemoglobin A1C or for cholesterol measurement across laboratories. So under the auspices of the Endocrine Society and funding from National Institute on Aging, we embarked on an effort to generate harmonized reference ranges. We obtained samples from 4 epidemiologic studies across US and Northern Europe. We harmonized the assays across these 4 epidemiologic studies through CDC's host program. And then we used regression, Deming's regression, to harmonize these values across different epi studies. We defined a lower limit of normal as the 2.5th percentile value, which corresponded to 263 nanogram per deciliter. 97.5th percentile value was 914 nanogram per deciliter. This defines the normal range in healthy young men and can be used across all CDC certified laboratories interchangeably. Across CDC certified laboratories, the values currently are almost interchangeable, and it has greatly reduced the diagnostic imprecision. However, these cut points should not be viewed as biblical dictum. In randomized clinical trials, testosterone treatment has generally improved sexual symptoms in men with baseline testosterone levels less than 300 nanogram per deciliter. And studies that have recruited men with levels over 300 nanogram per deciliter have reported little or no benefit in their sexual symptoms. So I think the reference range, the lower limit of normal, resides somewhere between 260 and about 300 nanogram per deciliter. But in this range, the risk of misclassification is high. This 20-year-old man requests evaluation for sexual dysfunction. He's well virilized, his testicular volume is 20 ml. Serum testosterone level is 299 nanogram per deciliter. The lab reports the lower limit of normal as 300 nanogram per deciliter. Insurance company is happy to approve testosterone treatment for this patient, and the insurance company would not have approved testosterone treatment for this patient if the level was 301 nanogram per deciliter. There's nothing more insane than this practice by the insurance companies. That aside, the assay, a radioimmunoassay, has a coefficient of variation of 15%. So what is the true testosterone concentration in this patient? Is it 299, 240, 360? The basic point in this rhetorical question is that you cannot tell from the available information. If the true value in this patient was 300 nanogram per deciliter, and the assay standard deviation is 15%, then the measured value has 95% probability of being reported within 2 standard deviations on any day. That is the value could be reported as 210 nanogram per deciliter on Monday and 390 nanogram per deciliter on Tuesday. Therefore, to approve testosterone treatment for a person with a value of 299 and to not approve it for 301 nanogram per deciliter is the height of insanity and total lack of rationale. So there is a zone of uncertainty around the cut point, and this resides within 2 standard deviations. So lower the value, the lesser the chance of misclassification. So if the total testosterone is less than 200 nanogram per deciliter, the chances that the person is eugonadal is very small. And as the value is greater than 400, then the chances that you will miss hypogonadal diagnosis of hypogonadism is also small. Diagnostic imprecision can be improved by multiple testosterone measurements over time. So if multiple testosterone levels are below 300, then the risk of misclassification is lower. By measuring free testosterone, using ancillary data, and checking biomarkers that I'll come to in a minute. So we've spent a lot of time trying to develop biomarkers of testosterone action that represent the testosterone-dependent proteome. So in this testosterone dose response study, we did a proteomic analysis and looked at 1,200 protein biomarkers. And of these, 6 were associated with testosterone dose and concentration. And 3 of these, changes in these were tightly linked to improvements in muscle mass and strength in this cohort study of testosterone dose response. And you can see that there is a nice dose response relationship between these biomarkers and testosterone dose and concentration. But we don't know how to clinically use these biomarkers. What are the cut points that we can use? But I think an approach which uses orthogonal biomarkers in addition to testosterone levels can reduce the risk of misclassification in that zone of uncertainty. So ancillary data can reduce the risk of misclassification when testosterone level is close to the cut point. So this 29-year-old man is being evaluated for sexual dysfunction and infertility. He started shaving at age 15 and became sexually active at age 18. He appears well virilized, but he has bilateral gynecomastia. His total testosterone is 310 nanogram per deciliter, just above the cut point, and free testosterone is 68 picogram per ml, just below the cut point of 70. Is he hypogonadal? You can't tell from this information. You need more information. If I told you that this person's testicular volume is 2 ml bilaterally, you would say, of course, he's got Klinefelter syndrome. And if I told you that his LH and FSH are 40 and 44 units per liter, you'd say, of course, give me the karyotype. And karyotype of 47 XXY would confirm the diagnosis, right? So ancillary data can greatly reduce the risk of misclassification when the values are in the zone of uncertainty. Testosterone, like other sex hormones, is bound largely to circulating plasma proteins, and 2 to 4% is unbound and is referred to as free testosterone. And free testosterone is measured by equilibrium dialysis. You dialyze the serum or plasma against a buffer that mimics the composition of plasma, human plasma, and unbound testosterone will equilibrate by crossing the dialysis membrane, and by measuring the concentrations of testosterone in the dialysate, you can estimate what the free fraction, what are the concentration of the free fraction. SHBG concentrations vary widely in men. And the most common causes that contribute to SHBG variability include common metabolic disorders, obesity, type 2 diabetes, metabolic syndrome. And SHBG concentrations are very tightly linked to total testosterone concentrations. So free testosterone concentrations are particularly important when patients have a binding protein abnormality, or when total testosterone levels are within 2 standard deviation of the cut point. Free testosterone can be measured, as I mentioned, by equilibrium dialysis. The other methods have higher level of imprecision, and tracer analog methods have been shown to be inaccurate and should not be used in clinical practice or research. People have also calculated free testosterone using various published equations, such as Vermeulen or Sodergaard or Mazur equation from total testosterone, SHBG, and albumin. The traditionally applied or published linear equations, such as the Vermeulen equation, are based on the idea that testosterone is bound to SHBG in a 1-to-1 stoichiometry with a fixed KD. And this assumption, our studies have shown, is incorrect, as I'll show you in a minute. Equilibrium dialysis is the reference method, which I recommend highly. The problem is that the equilibrium dialysis method has not been harmonized across laboratories, and the reference ranges vary across laboratories. So there's a great need for standardizing the procedure and generating population-based harmonized reference ranges. And we have done this and published a standardized procedure of equilibrium dialysis and published the reference ranges that are in this paper that you can look up. So the lower limit of free testosterone is about 66 picogram per ml. As I was mentioning, the idea that testosterone binds to SHBG with a fixed KD is not supported by experimental data. So the linear model is, it assumes that a single molecule of testosterone with a single fixed binding affinity. If using this linear model, the red dots show the predicted percent bound, but the actual experimental data is shown in black dots. So the experimental data does not conform to the linear model of testosterone's binding. And we've shown this also for estradiol. So both for estradiol and testosterone, the experimental data do not conform to the linear model. In addition, what we have found is that the apparent binding affinity varies dynamically with changes in SHBG and estradiol concentrations. So how is that possible if the KD were fixed? Our data suggest that the conformational or the three-dimensional structure of the binding pocket in each of the two monomers of SHBG circulates as a dimer. It changes dynamically with the concentrations of SHBG and the sex hormone. And this enables this dynamic change in the KD. And so if this video works, anyway, in this video, what I was going to show you was the changes in the conformation of the two monomers over a 5 microsecond time frame after testosterone's binding to SHBG. And you would have seen that the two monomers do not have the same conformation at any time, showing the dynamic changes in the three-dimensional structure of the two monomers and the allosteric interaction between the two monomers, which enables this dynamic changes in the KD. So what are the clinical implications of this intermonomatic allostery and dynamic changes in the KD of SHBG? And we've shown similar changes in the binding affinity of albumin. Albumin is a monomeриc protein, but it has 9 binding sites, at least 3 of which bind testosterone. This intermonomeric allostery and the dynamic changes in the KD extend the binding range. So for instance, estradiol concentrations change from 1 to 2 picogram per ml in menopause and prior to puberty to 500-600 picogram per ml during the pre-ovulatory phase to 20,000-30,000 picogram per ml during pregnancy. And this dynamic change in the KD with the ambient concentrations of estradiol and SHBG enable SHBG to bind such large range of concentrations of estradiol. Also, there's enormous class specificity. So SHBG binds sex hormones, estrogens, androgens, testosterone, DHT, phytoandrogens, phytoestrogens, SARMs, and SERMs, but it doesn't bind cortisol or progesterone. So enormous class specificity, and within class, enormous versatility in binding ligands within that class. The other implication is that legacy linear equations, no matter how well modeled they are unlikely to be valid in all clinical conditions because we don't know what the person ate, what phytoestrogens were circulating in the bloodstream, what cytokines were circulating in the bloodstream. So direct measurement by equilibrium dialysis is important, but if you're going to use calculated because the free by dialysis isn't available, I would suggest using an equation that models this intermonomatic allostery and the dynamic changes in the KD. And we've published this algorithm that you can download on your laptop or on your cell phone, and it's free. And you can go to truet.org and download it, or you can use the equation freely. The epidemiology of hypogonadism in men has evolved substantially. The classical syndromes like Kalman syndrome, there are more doctors studying Kalman syndrome than there are patients with Kalman syndrome. That is just the nature of medicine. We love interesting disorders. But in our analysis of the VA database, only 6% of the 150,000 men who were receiving testosterone treatment had classical syndromes, identifiable, diagnosable syndromes of testosterone deficiency or hypothalamic pituitary testicular identifiable disorders. Today, chronic prescription opioid use, obesity, and anabolic steroid withdrawal hypogonadism have emerged as common incidents of testosterone prescription in the US. Most men diagnosed with hypogonadism today are middle-aged and older men with obesity and chronic diseases. And the question is it safe and is it beneficial to treat such men? So obesity is a very complex, heterogeneous group of disorders, and SHBG levels are negatively associated with BMI, but men with moderate or severe adiposity, they not only have low SHBG, they may have true hypogonadism, as indicated by low free testosterone. And their obesity can contribute to hypogonadism by multiple mechanisms, including systemic as well as hypothalamic inflammation and gliosis, increased leptin, increased estradiol, and by other mechanisms that are not well characterized. So diagnostic accuracy can be improved by weighing the specificity of the symptoms and exam findings using an accurate assay, preferably an LC-MS assay, a CDC certified lab, and rigorously derived reference ranges. If LC-MS assays are not available, using an immunoassay that's certified by the CDC's host program or an accuracy benchmark can be helpful. Measure free testosterone using an accurate method such as the dialysis. And one should avoid diagnosis of testosterone deficiency based on a single testosterone measurement or only on testosterone measurement. And ancillary data that we discussed can help reduce the risk of misclassification. So in 1997, Peter Snyder, L. Matsumoto, Glenn Cunningham, 3 other preeminent andrologists of our time, we met at an andrology meeting in Seattle, and we thought about a large trial, randomized trial, to evaluate the safety and benefits of testosterone treatment in older men with hypogonadism. And we thought that if we powered the study for cardiovascular events and for fracture events, then that would provide sufficient power to look at prostate events and for all the other efficacy endpoints. So we responded to an RFA from the VA cooperative program. We were invited to submit an application. And after 4 years of review, the grant grew larger and larger and exceeded the entire annual budget of the VA cooperative program. So then the VA's leadership changed, and they said, well, this grant is just too expensive. So then NIA undertook 3 reviews over the next 3 years, and in June of 2003, it looked like we were going to get the funding for this grant in a much more abbreviated version. But then the Women's Health Initiative came out, and NIH put a moratorium on hormone research. The grant died with that moratorium. And then an Institute of Medicine panel was set up by National Institute on Aging leadership. They recommended much smaller efficacy trials. And they said that if we don't want to recap the Women's Health Initiative, and so if the initial studies show benefit, then we should do the safety trial. So that's how the T trials were funded in 2009. The paper came out on February 17, 2016, 19 years after the original grant was. So we thought that the cardiovascular safety trial was never going to be funded. So in 2013 to 2015, FDA held an advisory panel to review the cardiovascular safety because of the enormous and growing controversy about that issue. And this panel recommended strongly a randomized clinical trial focused on cardiovascular endpoint. And so they asked the pharma companies in the US to do such a trial. So that's how the TRAVERSE trial was funded, and Mike Linkoff and I served as its PI. And this was primarily, this was a modification of the original trial that we had envisioned in 1997. And this paper was published on July 16, 2023, 26 years after the original grant, but it was very satisfying. So T trials were designed as 3 linked efficacy trials: sexual function, physical function, and vitality. Enrolled 780 men 65 years of age or older, with an average of 2 fasting testosterone levels between 100 and 275 nanogram per deciliter by LC-MS, with 1 or more of symptoms of hypogonadism. Intervention duration was 1 year. TRAVERSE trial was designed primarily as a cardiovascular safety trial to assess effects on major adverse cardiovascular events. But because of its large size and long duration, 6 sub-studies were added, including depression sub-study, sexual function, anemia, progression from pre-diabetes to diabetes, and bone fractures. It enrolled 5,200 men, 45 to 80 years, with 1 or more hypogonadal symptoms plus pre-existing 3 or more cardiovascular risk factor or pre-existing coronary artery disease. So these men were at risk, high risk of cardiovascular events. 2 fasting testosterone levels, 100 to 300 nanogram per deciliter. Intervention duration was up to 5 years. So what did we learn about testosterone effects on sexual function? There's strong evidence that testosterone improves overall sexual activity, sexual desire, and correct symptoms of hypogonadism. The effect on erectile function was small and inconsistent. Marginally significant effect with 2-point benefit in the IIEF in the T trials, no significant effect in the TRAVERSE trial because the TRAVERSE recruited people with very high cardiovascular risk and ED risk factors. Strong evidence of no benefit. There was no beneficial effect in men who had normal T levels or no symptoms. This was the TEAM trial. And in another separate randomized trial, there was no improvement in ejaculatory function. 50% of men with hypogonadism in TRAVERSE had PHQ score greater than 4, so significant depressive symptoms. And about 15% had more severe depressive symptoms greater than 50. But dysthymia, which previously we thought was a specific syndrome in middle-aged men associated with testosterone deficiency, was uncommon. Only 1.5% of men in the study met the rigorous definition of dysthymia. In men with significant depressive symptoms and in all randomized men, testosterone improved mood and energy more than placebo. But in men who had severe symptoms and had clinical depression, testosterone did not improve their depressive symptoms. Testosterone is not a treatment for clinical depression. There were no significant effects on cognition or sleep quality. In the TEAM trial, which was a randomized controlled trial of 3 years duration, testosterone versus placebo, in men 60 years or older with total testosterone less than 350 nanogram per deciliter or low free testosterone. Testosterone increased lean body mass, leg press strength and power, stair climbing power, and aerobic capacity more than placebo. In TRAVERSE, 15% of men were anemic at baseline. Similar prevalence in the T trials. Anemia was corrected in a greater proportion of men in the testosterone-treated arm than in the placebo arm. Also, testosterone treatment was associated with reduced incidence of the development of anemia during the course of the follow-up in men who are not anemic at baseline. The rate of progression from pre-diabetes to diabetes in men who had pre-diabetes at baseline did not differ between the two study arms. Also, testosterone did not improve glycemic remission in men who had diabetes at baseline. The differences in change in hemoglobin A1C or fasting glucose did not differ between the two study arms. As I mentioned earlier, in 2010, a randomized controlled trial of which I was the PI was stopped by its DSMB because of increased incidence of cardiovascular events. However, the cardiovascular events were not adjudicated. The number of events was small, and the significance of the cardiovascular events was variable. But it led to enormous controversy, and epidemiologic studies, as well as retrospective analysis of EMR data, led to conflicting information and enormous controversy in the field. So the FDA advisory panel required the manufacturers of testosterone products to conduct a well-designed clinical trial to evaluate the cardiovascular safety of testosterone relative to placebo. Before the TRAVERSE trial started, we had completed a randomized trial of testosterone, the TEAM trial, to look at its effects on atherosclerosis progression and coronary plaque volume in older men over 3 years intervention duration. In the TEAM trial, the intima media thickness measured by ultrasound did not differ between the two study arms, nor did the coronary artery calcium measured by MDCT. In the T trials, we did coronary angiography to measure the plaque volume, and the total plaque volume did not differ between the two study arms, but the change in soft, non-calcified plaque was greater in the testosterone arm and the placebo arm. And this also raised some controversy because of baseline differences and the relatively small sample size of around 120 men. So TRAVERSE cardiovascular safety trial was designed to determine the effect of testosterone replacement therapy on major adverse cardiovascular events relative to placebo in older men who met the Endocrine Society criteria for hypogonadism and who had coronary artery disease or were at high risk by virtue of having 3 or more risk factors. So these 5,200 men who were eligible were randomized in a 1-to-1 ratio, stratified by pre-existing cardiovascular disease or risk factors to testosterone gel or placebo gel for up to 5 years. Primary endpoint was a composite of major adverse cardiovascular events, non-fatal MI, non-fatal stroke or deaths due to cardiovascular causes. So there were about 390 MACE events in each of the two arms, about 7%. No difference between the two study arms. Non-inferiority P less than 0.001. Amongst adjudicated secondary safety endpoints, the incidence of acute pulmonary embolism was higher in the testosterone arm than in the placebo arm. The absolute risk was small, but the relative risk was increased by about 50%. Among investigator-reported adverse events, these events were not adjudicated. The incidence of atrial fibrillation, cardiac arrhythmias, and acute kidney injury was higher in the testosterone-treated arm. Testosterone significantly increased RBC, neutrophil monocyte count, and increases in hematocrit were not associated with MACE events, but increases in neutrophil and monocyte counts were associated with venous thromboembolic events. And there are mechanistic reasons why that might be so, and the drug companies are developing drugs to reduce infarct size by preventing the egress of neutrophils and monocytes around the time of myocardial infarction. The most surprising thing was the low event rates of prostate safety events. There were total of 5 high-grade prostate cancers in the testosterone arm and 3 in the placebo arm. And similarly, low rates of any prostate cancer, 12 and 11 in the 2 arms. Other prostate safety events such as acute urinary retention, invasive procedures for BPH, prostate biopsies, and initiation of non-pharmacologic treatment for lower urinary tract symptoms also did not differ between the 2 study arms. The PSA values increased during the course of the study in both arms, and the increase was higher in the testosterone arm relative to placebo. The PSA data are not shown in this slide. The lower urinary tract symptoms shown in this slide, they did not differ between the 2 study arms. Testosterone treatment has been shown to improve volumetric as well as aerial bone mineral density in both the hip and the spine. And as well as improvements in bone strength. But one of the most surprising findings in the TRAVERSE was the higher rates of clinical bone fractures in the testosterone arm relative to placebo arm. And we don't know the reason for it. The trivial explanation is that testosterone-treated men became more energetic, and older men who were engaged in more physical risk-taking activities had more falls and more fractures. We really don't know the cause of this aberrant finding. So in summary, there is strong evidence that testosterone improves overall sexual activity and sexual desire in men with low libido. It relieves hypogonadal symptoms, improves mood, improves energy level, corrects unexplained anemia, prevents development of anemia, increases skeletal muscle mass, muscle strength and power, some measures of physical function, and reduces whole body and abdominal fat. It modestly improves walking ability and stair climbing speed, increases aerial and volumetric bone density and estimated bone strength. It's non-inferior to placebo with respect to the risk of major adverse cardiovascular events. And the prostate events, the incidence was very low in carefully selected men. There were very low rates of erythrocytosis when replacement doses and careful monitoring of testosterone levels to maintain T levels in the normal range was practiced in the 2 trials. Testosterone increases risk of venous thromboembolism and suppresses spermatogenesis. And in TRAVERSE trial, the incidence of atrial fibrillation, acute kidney injury, and bone fractures was higher in the testosterone arm than in the placebo arm. So testosterone treatment has some benefits, and it has some risks. But hypogonadism, as far as we can tell, is not a fatal disease. So in middle-aged and older men, an individualized approach to treatment decision, which balances the potential benefits versus the risks, and patient and clinician value seems warranted. And we use this approach in everyday practice in treating patients with different types of diseases. The decision to treat should weigh the diagnostic imprecision, the burden of symptoms, and the severity of testosterone deficiency against the potential adverse effects of testosterone and risk of monitoring, comorbid conditions that might increase the risk of adverse events, and the feasibility of alternate strategies, weight reduction, use of phosphodiesterase inhibitor to treat erectile dysfunction, improving glycemic control in diabetics. And finally, I think these decisions will vary with individual patients and their individual clinician. And there's no right or wrong answer, especially when the testosterone levels in the zone of uncertainty, where the risk of diagnostic imprecision is high. So with that, I want to end by acknowledging my debt to many colleagues and collaborators across the world who contributed to the data for which I've taken credit today. And I want to thank you again for your warm hospitality. Thank you.
Dr. Bhasin, thank you. That was lovely. I loved how you started with the clinical conundrums, so elegantly explained the biology, the physiology, and then ended with some sage advice. Maybe I'll get us started with questions. I was, with the Traverse data on PE, I was actually surprised to hear that there was no direct association between the hematocrit and pulmonary embolism, more on the inflammatory cascades, the neutrophils, as you mentioned. What's the mechanism behind that? You alluded to it, but I'd love to hear more about why it's not hematocrit, but mostly the white cells that may be associated.
So at a population level, higher hematocrit levels are associated with increased risk of hypertension and cardiovascular events and stroke events. But in the clinical trials, we have not found an association of increase in hematocrit with increased risk of MACE events or acute pulmonary embolism event. I think it may be that both in T trials, as well as in the Traverse trial, we used testosterone gel. The increments in hematocrit were relatively small, and it was also reflected in very small number of erythrocytosis events. In Traverse, there were like 3 or 4 people who were discontinued because of erythrocytosis, even at the lowest dose of testosterone. And I think there were about 6 patients in the T trial. So, but there is a huge amount of basic science data showing the mechanism by which increases in neutrophil and monocyte counts they contribute to increase in infarct size, poor prognosis in men. And it's been shown to be testosterone, and that mechanism has been worked out. And in addition, a secondary analysis of the tocilizumab trial to reduce infarct size, when it showed that there was benefit in mortality as well as in the infarct size in men, but not in women.
A follow-up question about VTE. If a man on testosterone replacement develops a VTE and has no other conventional risk factors, does the current association rise to a conventional risk factor? Should testosterone discontinuation be recommended? And if it is continued, should there be a consideration for extended VTE prophylaxis with perhaps a reduced DOAC dose in the long run, as long as the patient stays on replacement?
Yeah, it falls into the category of complex questions, send more money. I started off by thinking that testosterone does not increase the risk of VTE, but as more data has emerged from larger studies and from meta-analysis, and we've done an analysis of the VA database in 28,000 transgender people, and we have found that testosterone as well as estradiol treatment in trans men and trans women increases the risk of venous thromboembolic events. Combined with the Traverse data, I've come to believe that the risk is increased. Whether this is increased in people with pre-existing thrombophilia alone or in all people, it's not clear, but I think if a person has a VTE event and testosterone treatment needs to be continued as in trans men, then antithrombotic prophylactic, with an oral anticoagulant like factor 10 inhibitors might be indicated, but we don't have any randomized clinical trial. That's my bias.
Thank you, Dr. Bhasin. A fantastic body of work. Testosterone's prescribed in 2 primary formulations, intramuscular, transdermal. Do you have any insight into the safety or efficacy of those therapeutic approaches? Are they the same? Do they differ? The kinetics are different.
The kinetics are different, and the dose administered is substantially different. The traditional dose, starting dose for a testosterone ester enanthate and cypionate, which I believe is higher than what it should be, is 100 milligram, which contains 70 milligram of testosterone, the rest 30% being the ester. So divided by 10, that's 7. You're administering 10 milligram of testosterone daily, and the bioavailability is 100% by injectable route. But if you give transdermal testosterone, the starting dose may be 40 or 60 milligram or 1.62%. And nominal absorption is about 10%, right? So you're delivering 4 or 6 milligram, and the absorption is enormously variable. And we've shown data that half the people on starting dose of any gel have subtherapeutic levels. So I believe the erythrocytosis events are lower with transdermal gel because of the lower dose and lower levels. But the risk, it's my view, is related to the dose as well as the on-treatment concentrations. Dr. Veerman?
No, there you go. In a way, this will be a follow-up to what you just said. It's so important to have guidelines in this area that are updated and in line with what the trial has shown. I'm just wondering, in light of the Traverse trial being published, if we can anticipate new guidelines coming out, and if possibly androgel would be tiered above injectable testosterone in any future guidelines based on the evidence we now have.
Yes, I think the testosterone guidelines are in need of update because all the large trials data was published after the previous version had been published. But I think the guidelines are agnostic about the formulation and emphasize maintaining the levels in the middle of the normal range, regardless of the formulation. But I understand the thrust of your question. It's hard to take a position on the formulations because they are all FDA approved.
Yes, great talk, Shally, as always. I'm impressed that in your discussion of how to evaluate for testosterone need, you don't mention obstructive sleep apnea. And maybe it's because we live at altitude and most of the T trials were done in centers at sea level. But we see a lot more polycythemia and a lot more reversible, quote, hypogonadism if we treat the underlying obstructive sleep apnea. So I would say in our VA practice, it's glucocorticoids, opiates, and untreated sleep apnea. And we talked last night about whether in the future, it may be that if you treat also the obesity, the low testosterone improves. And I wanted to get your thoughts on that. Just as a comment to the practitioners, if we're going to give injectable, we've moved from the 200 every 2 or 3 weeks to 100 sub-Q as long as you mix it. And it usually needs it about every 10 to 12 days to keep the levels, but you have to adjust it if you have to use it, just as a practical thing. But your comments about sleep apnea, was that looked at in the Traverse trial? Was it not significant because of all the studies were at sea level? It's a big issue for us.
Yeah. In T trials, we're particularly attentive, and we didn't find, there was no new diagnosis of sleep apnea reported. And in Traverse, there were very few new sleep apnea events, but it may have been because of the selection process. And so that may have biased the findings. But I've been struck by low rates of sleep apnea. In animal models, you give injectable testosterone in young rhesus macaques, and they'll develop sleep apnea, and they develop hypertrophy of their neck muscles and laryngeal muscles and develop sleep apnea. So I think it's a pharmacologic effect, but very low rates of sleep apnea in Peter Snyder's original study of a couple of hundred people, and then in the T trials.
Dr. Bhasin, thank you for a lovely talk. We appreciate it. Thanks again.
Thank you.